Good morning, everyone. I'll be presenting a case report on unilateral advanced chemoresistant retinoblastoma. Thank you. So, I'm presenting a case of 3-year-old male child who presented to ophthalmology OPD with complaints of whitish pupillary reflex in left eye for last 6 months. According to his parents, the child was apparently asymptomatic 6 months back when they noticed a whitish reflex in pupillary area of left eye. It was not associated with any pain, redness, watering, or deviation of the eye. His prenatal, natal, and postnatal period was uneventful. Immunization status is complete as per his age, no developmental delay, and past history and family history was not significant. On examination, visual acuity in right eye, child was reading Leah symbol at 6 meters, and from left eye, he was denying any perception of light. On ocular examination, right eye was within normal limits. In left eye, Hirschberg reflex was 20 to 30 degree exotropia, and child was not taking central fixation from left eye. Pupil was mid-dilated, sluggishly reacting to light, and leukocoria was present. Rest anterior segment examination was within normal limits. This is a clinical photograph of the same child where we can see leukocoria present in the left eye. On fundus examination, in right eye, disc and macula was healthy, as we can see in this fundus photograph. In left eye, a large yellow color solid mass was seen right behind the clear lens, and no further details of fundus could be visualized. His radiological investigations were done. Firstly, ultrasound was performed at the time of presentation, where a heterogeneous echoic irregular lesion was seen 7.7 into 8.2 mm in size in the posterior chamber of the eye, abutting the lens anteriorly with macrocalcification. As we can see in this photo, there is macrocalcification. Then MRI was done, where a well-defined lobulated lesion was present in the posterior chamber of left globe with patchy areas of calcification. The lesion was iso-intense and on T1 weighted image and hypo-intense on T2 weighted image. These two are the axial and coronal section of the MRI T2 weighted images. On the basis of these clinical examination and radiological investigations, a working diagnosis of left eye retinoblastoma was made, IRCB classification group E. For treatment, we planned 6 cycles of intravenous chemotherapy, which were given at 4 weeks interval, carboplatin, etoposide, and vincristine in the doses mentioned. Then a repeat MRI scan was done at the completion of these 6 cycles, which showed a residual lesion with calcification, retinal detachment, and subacute vitreous hemorrhage. A repeat B scan was performed, where there was a residual partially calcified lesion 7.2 into 7.9 mm in posterior chamber of left eye with subacute vitreous hemorrhage. As we can see, the size has not actually shrinked on these B scan images. Since I did not show any response to the intravenous chemotherapy, thus enucleation was planned. Enucleation was done by myoconjunctival technique under general anesthesia, and the specimen was sent for histopathological examination. The histopathological examination confirmed the diagnosis of retinoblastoma and showed high-risk characteristics. This is a clinical photograph. The first picture shows the enucleated sample of the whole eyeball. Then in other 2 pictures, we can see the cut sections of the eyeball and the tumor done under the pathology guidance, where we can see a large white color tumor mass in the posterior segment of the globe. This is the histopathology report of the same patient, where we can see high-risk characteristics like choroidal involvement, ciliary body involvement, vitreous involvement, and subretinal space involvement. Further 6 cycles of intravenous chemotherapy was given at 4 weeks interval, and patient is now doing well with a well-fitted ocular prosthesis, and he's kept on 6 monthly follow-up. This is the clinical photograph of pre-operative and post-operative. My take-home message from my side is every child presenting to ophthalmology clinic should undergo a dilated fundus examination, no matter what the presenting complaint may be. And before operating any child for congenital cataract or any other grossly visible disorder, a B scan must be performed to rule out concomitant tumor in the posterior segment. During treatment of retinoblastoma, our aim is to save life first, then the globe, and then finally vision. Thank you.
In your case, the investigations which you did was a B scan and an MRI.
Yes, sir.
Why did you choose MRI and not CT?
Because sir, the soft tissue, for soft tissue we do MRI. So we wanted to know the extent of the extraocular muscle involvement and the soft tissue involvement.
Your clinical diagnosis was retinoblastoma?
Yes, sir.
So which is a preferred modality of radiological investigation in a retinoblastoma case?
Sir, CT scan can be done because calcification and other things are there, but we wanted to see the involvement of optic nerve, extraocular muscles, because we were actually planning.
So that can be seen in CT as well, when you need to rule out pinealoblastomas and calcifications. So preferred choice is CT scan, if
Yes,
I'm not wrong. And secondly, the size of the tumor which you mentioned was pretty small.
Sir, it was involving more than 50% of the globe.
You said less than 10 millimeters.
Yes, sir.
How can that involve 50% of the globe then? Less than 10 millimeter is 1 centimeter.
Sir, in ultrasound, the dimensions were 7.7 and 8.2, but when we confirmed with MRI, its size was around 10.6 in the longest diameter. Ma'am, it was 21 point. Yes, ma'am.
And in the grossing also, the tumor, the white part was in the centrally placed rather than on the posterior aspect. More
Yes,
so.
sir. But it was abutting the lens also. It was seen right behind the clear lens, and it did not show any improvement on intravenous chemotherapy. We thought of giving another 4 cycles of intravenous chemotherapy, but size did not shrink at all. So we went ahead with enucleation. And at that time, at my center, there was no option of intra-arterial chemotherapy, and so we landed up with enucleation only.
Yeah, there are a couple of differentials which very much mimic retinoblastomas.
Yes, sir.
And the way the presentation is that it's so anteriorly lying, it's not responding to any of the 6 cycles. Hardly there was a response.
Yes, sir.
And the age is 3 years.
Yes, sir.
So,
Yes, sir.
I actually had a case when I was doing my fellowship, which was mimicking retinoblastoma. We did enucleation. Later, it was found to be something else. So you have to be, and the histopathology was really tricky in that case. Probably, no, vitreous biopsy is not advocated because the patient did not have vision. The patient was not getting salvaged with the chemo. So, and the high suspicion of retinoblastoma was there. And her slides, she later said there was a high risk factors were there.
Yes, sir.
Did you do the adjuvant chemotherapy later?
Yes, sir. We gave 4 more cycles of chemotherapy.
4 more cycles.
Yes, sir.
So,
No, ma'am, there was no involvement. Ma'am, in our case, we could excise only 7 mm, but ideally it should be at least 10 mm. But we could salvage only, we could take out only 7 mm. Thank you, sir. Thank you, ma'am. Thank you, everyone.